دكتور أيمن نقدر نبدأ دلوقتي.
Thank you. بسم الله الرحمن الرحيم. السلام عليكم جميعا. This is Dr. Ayman Al-Hijazi, hematologist from King Abdulaziz Medical City, Riyadh. It's my pleasure and honor to welcome you all in our first wave of Transform Myeloma virtual series, which is under the umbrella of the Saudi Myeloma Working Group. This webinar tonight is sponsored by Johnson & Johnson, and this is the first wave of many to come, which is going to be on monthly basis. Challenging cases and update in plasma cell dyscrasias will be discussed on monthly basis. And thanks for everyone that has joined tonight. Our tonight's talks are going to be presented by a dear colleague of mine, Dr. Ghazi Al-Ataibi, who is a founding member of the Saudi Myeloma Working Group and is a professor of hematology at King Khalid University Hospital, King Saud University. He is going to present two very challenging, very interesting cases. The first is going to be a dysproteinemia case in focus, and the second is going to be a myeloma challenging case. After each case, we will have a short discussion. So if you have any question regarding the case management or otherwise, please post your question in the question box, and we will try to deal with it after the presentation. Dr. Ghazi, floor is yours. Go ahead.
Assalamu alaikum. Thank you very much, Dr. Ayman, for the kind introduction. Thank you to the Saudi Myeloma Working Group for the opportunity. I think it's actually a great opportunity to discuss, challenging myeloma and dysproteinemia cases on a monthly basis. And in this case, or in this month, we thought we choose two cases from different spectrums of dysproteinemia. So in today's talk, is actually sponsored by Johnson & Johnson Innovative Medicine, and these slides are actually prepared by the speaker, and I've got no conflict of interest to present pertinent to this presentation. The first one is a 36-year-old gentleman who came to the emergency department with palpitation, and part of the workup that was initially done reviewed acute kidney injury and hematuria. So, on taking further history, this young man did not have any past medical history. He is not on any biologics or any medications, does not have any family history of any hematolymphoid malignancies. So, a 36 years old, palpitation, found incidentally to have AKI and hematuria. So, on the time of diagnosis, which is in November 2021, his hemoglobin was borderline abnormal, so it's 12.7, really nothing impressive with a normal MCD. So normal cellular chromic anemia, the cell counts are actually quite okay, but his kidney function took actually a bad hit. So his GFR dropped significantly from a normal range of 90s in his age group to something in the range of 55. So all other workup for kidney disease was unremarkable. So his albumin to creatinine ratio is 5. So this is a non-albuminic acute kidney injury with no elements of autoimmunity, with a normal C3, C4, and ANA negativity. So unfortunately, it took this guy 6 months to see nephrology. So from November to May 2022, he saw nephrology, and at the time of second investigation, his kidney function revealed a tiny bit worsening in his creatinine. So it went from 127 to 137. So this is a tiny bit indolent process, but it tells you that this is actually a progressive case. And the hematuria is more frank now, so he's got an RBC in the urine, so microscopic hematuria. Blood is positive, sometimes 2 plus, sometimes 3 plus, but there is no proteinuria, which is very interesting. So the nephrologist has been quite thorough in his workup. So they did all sort of AKI workup, including serum protein electrophoresis, which I thought this is actually a great way to investigate acute kidney injury of unknown etiology. So in this case, it was realized that he's got a monoclonal gammopathy, an IgG type, an IgG lambda subtype. So his immunofixation was positive. The amount of M protein was actually very small. but his disease burden is mainly lambda, and it's about 112 milligram per liter. And again, I have to realize that this is a there is no albuminuria, there is no proteinuria. In a 24-hour urine sample, he only had 102 milligram of protein. So this is a kidney injury likely related by an IgG lambda disease process with no element of proteinuria. So it's really not consistent with a picture of amyloidosis. So ultimately, this is what the immunofixation have shown, and then the size of the lambda clone is 112. So it's a tiny bit significant for a kidney disease. And usually, the most common question that comes in mind always is, this is a 36-year-old guy, so I think the tendency to do a renal biopsy is probably much lower in young people, but in older people, I think we still have to think about kidney disease, kidney biopsy in those patients who come to the clinic with a possibility of MGUS in addition to AKI, or the combination of both. So we thought this could be an MGRS, and we went through the exercise of, this is a guy who's got an acute kidney injury, stage 1 or 2. Yes, there's no proteinuria, but there's a hematuria, and there's an evidence of light chain involvement. So a kidney biopsy was done in this guy. And surprisingly, this is the kidney biopsy report that we got from the renal pathologist. So he mentioned that the sample is actually good enough for evaluation, but it has a predominantly kappa-restricted, a lambda-restricted deposition, and excess staining is seen mainly in the glomerular cavity wall. So it's about 2+. There's some element of involvement in the tubular basement membrane, but the picture is suggestive of a lambda deposition in the glomeruli. And these are actually the glomeruli of the patient. So these are pictures from the electron microscopy under the immunofluorescence. So moving on, if you actually see the EM report, you can see there's a significant process of MPGN. So there is a dense material that are non-fibrillary in nature. So there is no fibrillary process. So this is an inorganized, fibrillary process with deposits in the glomeruli. There's a significant element of autoimmunity, I would say, or an immune activation. So there is something involving the tubules and the glomeruli. Takes a lambda restriction pattern, and it's actually not organized, and it's not fibrillary in nature. So it is definitely not going with renal amyloidosis. So the final report, as you can see here, he called this a light chain deposition disease with an MPGN, which is, interestingly, if you actually look at the international kidney and monoclonal gammopathy consensus, this is actually a distinct entity. And the description of light chain deposition disease with MPGN has been actually well described, and usually it comes with heavy chain as well as light chain. So MIDD with MPGN is a distinct entity, and in those patients who come with MGRS associated renal disease, so monoclonal gammopathy of renal significance, we always look at them as, do you see deposits in the biopsy? And in this guy, yes, we saw deposits. And is this organized or inorganized? It was actually non-organized deposits. They're actually not fibrillary in nature, and so that falls under the umbrella of monoclonal immunoglobulin deposition disease. Mostly, it's a kappa-mediated disease, but lambda has always been reported in about 20-30%. So it's not impossible to see a lambda as we saw in this guy. So moving on, so in the IKMG consensus, lesions with non-organized deposits, most of the cases are, it comes with a proliferation and glomerulonephritis, so peripheral glomerulonephritis with the monoclonal immunoglobulin deposits, and we thought this is the diagnosis we had in this guy. So now you've got a young guy who comes with a hematuria, no evidence of proteinuria. His kidney disease is getting worse and worse with time, so there is evidence of end organ damage. What is leading to this organ damage? We have to start the journey to identify the clone. So in people with MGRS, I think this is a well standardized disease entity since 2012. So the last 12 years, MGRS has been well described in the literature. And for those patients, you have to do a serum protectophoresis with immunofixation. You have to do a UPEP with immunofixation. A 24-hour urine protein is super important in those patients. Free light chain assay on the serum, a bone marrow biopsy, a low-dose CT, sometimes a lymph node biopsy, especially those people who comes with imaging that shows lymphadenopathy. The clone could be a CLL clone. It could be any lymphoma clone. So a lymph node biopsy can be helpful. A preferable for CLL if it's something identified on imaging, and a FISH for translocation 14 and BCL2 by immunohistochemistry. So if you actually look at the spectrum of MGRS, AL amyloid is mostly a plasma cell clone in almost all the cases. Rarely, sometimes it comes with Waldenström macroglobulinemia. Sometimes you see an IgM lambda. But in the MIDD, so monoklonal immunoglobulin-inducing disease, comes in plasma cells most of the time. Light chain proximal tubulopathy, also a plasma cell clone. Immunotactoid is a CLL mostly, and proliferative glomerulonephritis with monoklonal immunoglobulin-inducing disease comes with a C3. So most of the time the evaluation is negative, but you can see an MGS clone with it. So in our guy, we went ahead and did a bone marrow biopsy, and this is no surprise to people who saw the lambda light chain on the serum. So this is coming from the bone marrow. So he's got about 8 to 10% lambda restricted plasma cell. So there is a small clone that's actually, I would say this is more of a benign clone, but it's causing a toxic damage to the kidney. So you really have to think about, how can we prevent this damage from happening? And in this guy, at one point, I thought it might be possible, or it might be a good idea to rule out, amyloid, completely out of the picture. So we went ahead and did a cardiac MRI, and it was actually completely negative. We went with a fat pad biopsy to see if there's any amyloid deposits everywhere, and everything came back negative. So the only organ that's involved is the kidney, and the pathology or the pathophysiology of damage is an amyloid deposits. It's more of a crystallization, more like a light chain, deposition happening on the basement membrane and leading to this hematuria. So this is an impressive images that you can see from the New England paper by Nelson Leong from 2016, and he actually went ahead and described the pathophysiology of all common MGRSs. So in the AL amyloid, you've got the organized fibrils depositing on the podocytes. So it actually infiltrates the basement membrane, and due to the misfolding, it actually deposits in a very nice organized way. But if you see light chain deposition disease, most of the time these are actually positively charged, or sometimes glycosylated light chains, and they're very toxic to the basement membrane. So the process is an MPGN process. So it's an irritant to the basement membrane. But luckily sometimes you see the light chain deposition taking the immunofluorescence. So that's how you establish the diagnosis. And then all other MGRS has been described in the paper. So I really encourage people to have a look at it anytime they see an MGRS case. So the light chain deposition disease, whether this is the coming with a bad kidney disease or even a normal kidney disease, most of the time, we treat it as a light chain amyloidosis. So the therapy is a clone-directed therapy. So we really have to get rid of the clone to allow for the kidneys to heal. So we started him on data VCD for the usual 6 cycles based on the Andromeda, and impressive. This thing we've never seen prior to initiation, prior to the era of anti-CD38 monoclonal antibody. We've never seen somebody goes from a baseline 112 lambda to a lambda light chain of 6. So this is an impressive response. If you actually follow the renal amyloidosis response criteria, this is a CR in 1 month. I don't think the criteria applies here. Like, I don't think the kappa to lambda difference of less than 4 that we usually talk about in renal amyloidosis applies to this case in particular. But, I thought this is quite impressive. So this guy had a very impressive heme response. So a peripheral blood response has been good, but the kidney response lagged behind, and this is something you also sometimes expect. The red cell in the urine after 4 months of therapy went from 50 cells per high power fill to 3 to 5, and the blood was only just 1 plus, and it actually remained the case throughout his therapy. So after completing six months of therapy, we repeated the SPEP and free light chain, which we've been doing every month actually, this guy. So everything came back negative. Everything came back normal, his kidney function normalized, the hematuria resolved, and I thought we'll just repeat the 2-5 urine just to see, is the proteinuria, maybe it was actually in the rise at the time of diagnosis, but his proteinuria has been, is normal. He does not have any protein in the urine. So speaking about lagging response in organ response in amyloid and some NGRS diseases. So Eli Mokhtar from Mayo has published this data in 2018, and they looked at their own all patients with amyloidosis, and you can see the best predictive response most of the time is if you close the tap and the heme response goes back to CR. But the organ response takes a long time. So if you're looking at somebody with cardiac amyloidosis, time to a maximal response after treatment initiation in cardiac amyloid is actually 2 years. So it takes a long time for the heart to remodel and go back to some extent to a better shape, but not necessarily to a maximum normal shape. In the kidney disease, it's even worse sometimes. So the proteinuria, the maximum response to improvement in proteinuria takes about 29 months. So that's a long time. So you're looking really at people at 2 to 3 years, for the proteinuria to completely disappear. And more than 30% response usually happens at 6 months. So this guy did not present with proteinuria, but his hematuria improved significantly, which tells you that this is probably a direct toxicity from the light chain. So now, how do we treat light chain deposition disease? I think the right answer is we don't know what is the right treatment for light chain deposition disease. I mean, we extrapolate from the renal amyloidosis. This is what the International Kidney and Monochromatic Gammopathy group suggests. This is what most of the myeloma community has been doing for a while, which is a clone-directed therapy. If the clone is a CL clone, then you go for a CL-directed therapy. If the clone is a Waldenstrom clone, then you go for an indolent and Hodgkin lymphoma therapy, and so on and so forth. So we did a database therapy based on the Andromeda. And the Andromeda has been actually a very important study in amyloidosis. This is the first trial that led to the approval of daratumumab as the first medication to be approved in amyloidosis. There is no medication after this and no medication before that was approved for light chain amyloid, whether this is cardiac amyloid or all comers amyloid. And in the Andromeda, what they did is the standard of care is VCD, so they added to the VCD backbone. So those patients will get a DARA plus VCD, they'll get it for 6 months, and then ultimately they'll get a maintenance for 2 years, which is not something most of the people do. In the control arm, VCD will continue for 6 cycles, and then you stop treatment and you observe it. In the Andromeda, there was no design for an autologous stem cell transplantation. So looking at the primary endpoint, which is a heme response as a primary endpoint, you can see 60% achieved heme response really early on therapy. So most of the responses happen within 1 to 2 months, compared to only about 20%. And then the involved free light chain, or the difference between involved and non-involved, went to less than 20, much higher in the daratumumab VCD arm compared to the VCD arm. The difference went significantly less than 10 in the literally, doubling the VCD, just only by adding daratumumab, and the ISA, CR definition went from 20% historically to 50%. So these are impressive responses that people have seen only within 11 months of follow-up. And the event-free survival on that, there was actually quite a bit of a plateauing in the data VCD, with numbers, really above 80% event-free survival compared to 60%. So the addition of daratumumab to VCD in any amyloid case will lead to deeper responses, earlier responses, and improvement in event-free survival. So now, going back to the, my slides are moving a tiny bit faster than me. Okay. Okay, so when it comes to organ responses, higher organ responses have been seen with DAR-VCD, which makes total sense. So at 6 months, DAR-VCD has led to 42% cardiac responses as per the ISA criteria, compared to 22%. So there's almost a doubling of response anytime you had daratumumab, even at either at 6 months or at 18 months. Renal response have also showed the same. But if this is going to show us anything, it tells us that VCD is not really enough for those patients. The maximum response you get at 6 months is about 20%, and even at 18 months, the response doesn't actually improve. So whatever response they get at the beginning, the clone becomes really refractory to VCD. I don't want to spend too much time on the details of the study. It has been published in a long time ago, but if you actually compare it to other studies that looked at VCD, there is a significant improvement in quality of life when daratumumab has been introduced in all PRO's scales. So I think the Andromeda has set the standard of care in amyloidosis. Now, did it answer all the questions? I think the answer is absolutely not. So if you actually just take the flow sheet, the flow diagram, from the time of randomization, the first unmet need, to be honest, is actually, 60 to 65% achieve CR at end of induction, so at 6 months. But you're also looking at 40% who do not achieve CR. So what do you do with those patients? The clinical trial was not, looking at consolidation or a transplant. So that's something we really have to look at. Most importantly, at the time of inclusion, which is something we always wonder about, is people who come with a cardiac amyloid advanced stage or stage 3B, people who come with advanced renal disease, or people who are not really doing clinically well, they were actually excluded from the study. So we don't know what to do with advanced stage, cardiac amyloid, whether you go by European stage 4 or the Mayo classification stage 3B. The other thing is, what's the benefit of daratumumab maintenance? If somebody achieves a CR, do you have to take them for 2 years on maintenance? This is not the common practice, I can tell you. So most of the amyloid people don't actually go for maintenance at all if somebody achieved a CR. If not, then maybe you can make a case for either a transplant or maintenance with daratumumab. And the other thing is, if somebody progressed, can you go back and retreat again with daratumumab? We don't have a clear answer to this. So what's the role for transplant? In the next probably couple of minutes, I'll just quickly talk about, transplant in amyloid. The overall survival is actually, prior to daratumumab, was actually not great, even with VCD. So people have actually added on melphalan as a consolidation just to kind of improve the response. And the duration of hematological response is the best the best hematological response prior to transplant is the best predictor of outcome after transplant. And the organ response, if somebody comes with a better organ response after transplant, they do very well. So after transplant, if people achieve the CR, their chances of having an improvement in survival is much higher, with a CR versus no CR versus VGPR and so on and so forth. And this is in all sort of organs, so renal response, cardiac response, and liver response. So it doesn't matter if you transplant somebody with 1114. We know that the majority of patients with amyloidosis comes with the transcript 1114, so a cyclin D1 type mutation. The difference doesn't matter. So are those people more responsive to transplant versus not? I mean, there's no difference in overall survival or mortality or PFS. So I think 1114 doesn't actually make a distinction. And do you have to go for a transplant in those who only had a VCD, not daratumumab-based therapy? Again, all data from registries have shown that those who received bortezomib-based regimen and did not receive transplant did worse. If you actually flip the case and say, well, now if VCD is not a good induction therapy, should we just take those patients to transplant ahead and not even induce them? Most of the literature suggests that instead of taking to transplant from the beginning, a short duration of induction might actually make them more tolerable to transplant, might actually improve their outcome. So ideally, it's nice to give them induction therapy prior to transplant. This is an old data and old practice. So back to our case. This guy have only received 6 months of therapy, went into complete hematological response and good organ response. 2 years after therapy, so I continued to follow this guy every 3 months with light chains, and now his light chains looks good. His immunoglobulins have been back to normal, albeit in the lower range of normal. Some element of immunoparesis, but he doesn't have any infections, and his light chain has normalized, so he's getting immune reconstitution. But surprisingly, his immune fixation came back positive now. So no hematuria, no end organ damage at this point, with his clone is back on the immune fixation. So this is really an alarming sign. So now, should we be worried? I think if you actually look at the literature, you can see that people who get even a very small amount of light chains, they continue to have worse outcome. So even small amount of light chain can be very toxic to the organs. So the only literature we have on this is from cardiac amyloid. So those who had an ATTR protein, whether this is a wild type or a hereditary TTR protein circulating, they don't do as bad as those who get a light chain circulating in the circulation, even at a smaller amount after achievement of complete response. So presence of light chain per se is not a good thing, and our guy will probably have a relapse of his disease sometime in the future. Can we use MRD testing? Maybe we could have actually did an MRD testing at the time of end of therapy to improve on our detection. So we could have just said, this guy did not achieve CR. He's getting a mass spec positive disease from the beginning. We should have consolidated him with a transplant. I mean, I guess this is something for the future. We don't do this right now, but I can tell you that, people who've got a free light chain positive disease, they don't do, as good as those who are MRD negative by mass spectrometry. And the data confirms that even there's a survival advantage if you actually follow those with mass spectrometry based MRD testing. So back to you, Dr. Ayman.
Thank you very much, Dr. Ghazi. This was really a very interesting case. There are many, I guess, questions and answers in the treatment of these patients because of the rarity of the disease, probably. And all what we do is extrapolation from what we do in amyloidosis mostly. Just wanted to clarify a point to the audience. I mean, plasma cell dyscrasias are classified into different categories. Multiple myeloma, the full-blown plasma cells secreting a paraprotein. And everybody knows about MGUS, where we have less than 10% plasma cells in the bone marrow, plus a small paraprotein. Now, what Dr. Ghazi has been talking about of MGRS is a new entity which was used to be called as Londonly MGUS. Now, MGUS is now subclassified into many subcategories, including MGRS, and lately there has been MGTS of thrombosis, a paraprotein that drives thrombosis. And there are many other subclassifications of MGUS. So basically, it's part of MGUS, but leading to end organ damage, and that necessitates the treatment. Now, Dr. Ghazi, you have mentioned in your talk the differences between amyloidosis and the light chain deposition disease. Can you highlight those points, because this is important for the audience? I mean, whenever you do a serum-free light chain and you have a serum-free light chain that is either lambda or kappa that look monoclonal with an inverse ratio or a very high ratio based on whatever is the dominant light chain, I mean, what do you have to go through? How do we diagnose multiple amyloidosis, Dr. Ghazi? Just for the audience to know.
I mean, that's actually a good question. To be honest, I mean, NGS is a common entity. It happens in some in the range of 4 to 6% in the population, as we age, and so this is a common benign disease. And the goal of the first visit is always to confirm two things. Number one, is this an evolving myeloma that has not been diagnosed, and this is the first time you see them? So that's why most people, I would always see them day one and in 6 months, first visit. And then the first goal in the first visit is to look for any end organ damage. So the NGS could be could lead to a myeloma, but also could lead to amyloidosis. And the entity you mentioned, the monoclonal gammopathy of clinical significance, this is a really evolving entity. So it can have a cutaneous manifestation, thrombotic manifestations, and also neurological manifestations and renal manifestations. So it's, again, the goal of the first visit is make sure there's no end organ damage. That end organ damage will require a search, and the advice is always to look at the usual CRAB criteria, make sure there's no bony symptoms, and at the same time look at the renal panel. So if there is proteinuria, even in the absence of Prince Jones, because Prince Jones is a free light chain that comes in the urine. So this is a myeloma, not amyloid. If you see a proteinuria with MGS, it's very important to establish a multidisciplinary team approach to these cases, because this is when you diagnose renal amyloidosis. So it's usually albuminuria, it's usually proteinuria, and usually comes with a lambda light chain. I would say 9 out of 10 cases.
Yes, I agree with you. So, I mean, it's an entity that needs to be kept in mind, where you have a small clone of B cells, whether plasma cells, of mature B cells like plasma cells or otherwise, that secrete some form of light chains. And the main issue in amyloidosis is the deposition of microfibrils seen under the microscope with light birefringence and the Congo red stain as usual. And then you go down the battery of tests trying to find out the clone. Well, I guess because of time, I don't see any questions from the audience unless they are not posted in the chat box. So Ahmed, if there are any questions, please post them in the chat box so we can at least discuss them. So we'll go to the next case, Dr. Razi.
Okay, sounds good. Case number 2 is definitely an easier case. So this is a 68 years old lady who came to the clinic with abdominal pain. So as usual, it took her literally several months to go through the pathway of abdominal pain. And ultimately, she saw a gastroenterologist who decided to do an upper GI scope. And in the upper GI scope, which is very surprising, she had what looks like a pyloric lesion. So it was a salmon-colored lesion. It's not like gastritis, not an ulcer. It's more like a salmon-colored elevation in the pylora. So it's also involving the antrum, but to mostly it's a pyloric lesion. So they took actually multiple biopsies, to diagnosis, and also they did what we call it, a mapping biopsy. So just to see, which is the extent of this lesion. So that's what they did, and they also did the basic labs, and everything is completely normal. Everything is pristine in this patient except the pyloric lesion in images and the fact that she's got abdominal pain. So they did a CT chest, abdomen, pelvis, and there was actually no mass in the stomach. The pyloric lesion is not existent. She doesn't have any stenosis. There's no thickening. No lymphadenopathy. There is no nothing in the neck, nothing in the chest, nothing in the abdomen. So there was actually a surprise. So they waited and waited for the pathology, and the pathology have actually showed something that we see every, I would say, maybe couple of years, a gastrointestinal involvement by a plasmacytoma. So this is a plasma cell that is strongly positive for CD138. It's also kappa restricted. So I think the morphological and immunohistochemical diagnosis was suggestive of gastric plasmacytoma. So this is an extramedullary solitary plasmacytoma. So if you look at the International Myeloma Working Group, definition, plasmacytomas, we always define them into, either is this a solitary lesion or is this a solitary lesion with a minimal bone marrow involvement? But the thinking is always these are actually osseous lesions. These are actually medullary lesions. They're, plasma cells do not survive outside the bone marrow. So usually they're juxtamedullary. They're just really beside the bone. But if you look at the criteria, they also talk about soft tissue involvement. So you could get a soft tissue mass with evidence of clonal plasma cells. And if you really want to call it solitary plasmacytoma, it has to, this patient needs to have a normal bone marrow with no evidence of clonal plasma cells in the bone marrow. The CT scan or the MRI, should be completely negative, apart from the area where the disease is, and there is no evidence of end organ damage that can be attributed to plasma cell neoplasms. So in this patient, the first step is really look for the clone. Is this a systemic disease or is this a localized disease? So the bone marrow biopsy came back completely normal. So there's no evidence of any plasma cell dyscrasia. All the plasma cell clone, albeit very small in the bone marrow, is polyclonal. So there is not a clonality in the bone marrow. So, remember when we talked about CT? So we said we did a CT, the CT scan was actually completely normal. So the next, step that, we really have to always look at is, always look for the best available modality of imaging to identify extramedullary disease, because the PET scan in this case have actually, if you can see here, this is the area of the pyloric lesion. Very avid, the avidity or the SUV uptake is something in the range of 15 to 16 SUV max. So something similar to the kidneys. So if you see the kidneys, this is where the contrast is being excreted. The pyloric lesion is actually quite big, and it's quite dense and quite avid. There is no other activity elsewhere. So the serum, which is very interesting because the bone marrow biopsy was negative, but the serum showed actually an IgG kappa clone. So the kappa is mildly elevated, 58 milligram per liter. The ratio is 3.3 in somebody who's got a normal kidney function. And the IgG is 16 with some element of immunoparesis. So you see the IgM is, a tiny bit in the lower side. The IgG is actually elevated, and IgA. So the IgA is also elevated as well. So, but the immunofixation showed actually an IgG kappa. So no M spike, kappa is high, lambda is normal, ratio is 3.3 with normal kidney function. 3.3 with normal kidney function is not normal in any way, shape, or form. So we did a, we thought, maybe there's some other lesions that, maybe some other plasma cell islands that, we're missing. So we did a whole, MRI of the spine and the pelvis, and it came back negative. So what is the diagnosis here? The diagnosis, I think, is a solitary extramedullary plasmacytoma. This is a disease entity that's been, not clearly described in the literature. The incidence of extramedullary plasmacytomas is actually rare. So looking at the SEER data between 1992 to 2004, they report, 0.1 per 100,000 person per year. And if you see the European diagnostic criteria for plasmacytomas, they always emphasize on the need for a PET scan, and this is something we always, try to preach all the time. Is PET scan is probably the best modality for extramedullary or even any solitary plasmacytoma, because it has a very high sensitivity, as we showed in this case. So the CT was negative, but the PET scan was positive, with a 99% specificity to evaluate treatment response. And also to diagnose those patients at the time of diagnosis. So the treatment now becomes a difficult question. Should we do radiation only, or should we do radiation with 1 year of systemic therapy in somebody who's got a serum IgG lambda with negative bone marrow, but one focus of disease in the stomach? So it's an extramedullary disease. And then if you do the treatment, what is the best predictive response? I've always thought that if somebody comes with a a light chain coming from the plasmacytoma itself. If you irradiate the plasmacytoma and the light chain is normalized, this is probably the best predictor of response. But is this truly the case? We don't have strong data outside small case series coming from Maury Gertz and his group. So I thought the take-home message from this case is PET scan is extra important in extramedullary plasmacytomas, and in this case is the best example. And there's no, in my mind, there's data to support adjuvant chemotherapy to improve relapse rate. So those people are usually treated with just localized radiation. But I wanted to hear from you, Dr. Ayman, from other colleagues in the Saudi Myeloma Working Group.
Well, thank you, Dr. Razi. Again, another interesting case, really, a solitary extramedullary plasmacytoma, which is not the usual site for solitary plasmacytomas. I would agree with you. Now, many of the plasmacytomas, depending on the size and probably the subtype, are associated with a small paraprotein. There is no myeloma picture. You do the bone marrow, it's completely normal. There is no clonal plasma cells. And as you have suggested, most of the time we treat those with radiotherapy alone, and we keep on following them up. Definitely there is a number of patients that will transform into full-blown picture of multiple myeloma or relapse in multiple sites where you need to treat them systematically. This is at least my experience. If there is anybody else that would like to comment. Any comments?
Yes, thank you, Razi, Dr. Ayman. It's a very, honestly, very, very interesting two cases. Rare, not easy. Honored speaking.
Yes.
After you spoke to me, Razi, I actually kind of went to review, and it does seem you're right. Radiation alone seems to be the way in these cases. I think the best thing that, in terms of prognostication, is that the patient had no marrow involvement, and it seems to make the difference in terms of the outlook in the future. I think their progression rate significantly worse to a multiple myeloma in the future if they have marrow involvement. I think the progression to myeloma in a pure solitary plasmacytoma with no marrow involvement is really, I think it's a single digits or something around 10 to 15% at most. But yeah, I believe that single radiation high dose 40, 50, or some even advocate up to 60 grays would be the way to go.
Yes, thank you, Dr. Omar. Any other comments?
Yeah. Thank you, Dr. Ayman and Dr.
Yes, Dr. Till. Yes, go ahead.
Just my experience, it's not very common solitary plasmacytoma in Saudi Arabia. I feel I've seen very few cases, most patients present advanced. What I have seen is sometimes you see minimal marrow involvement of just 1 to 2% clonal plasma cells or a very small paraprotein. But I think, in my experience, they're all done well with just local radiation, and we just follow them. Some of them, I think, probably 3 or 4, they disappeared, and then there's a small paraprotein, and others have persisted. I can't remember if anybody transformed to myeloma. And also, I want to comment on the previous case, Dr. Razi. You said in the flow cytometry there are 8 to 10% plasma cells. So, was the Trifine also showed similar plasma cells, and also did you do any PET scan or MRI? Because if it is 10%, then it qualifies for myeloma.
Right. So the maximum amount of cells, we went back and re-evaluated this. So it's maximum on the Trifine is 8%. So the maximum in the highest number of plasma cells in both Trifine, biopsy, and flow is 8%. And then on repeating the bone marrow biopsy at the end of induction, that's actually a great question. So end of therapy, bone marrow is actually completely normal.
Okay, because you mentioned in the flow cytometry 8 to 10%, so that's why I thought whether it's borderline. So, yeah.
And the other thing, I mean, the management was given. I mean, it's similar to what we do in myelomas with renal impairment. I mean, data BCD is what the patient has received. It's just that the comment about whether you need to really subject this patient to transplant or not, that becomes an open question. If this was amyloidosis, I would have done that probably, subjecting him to transplant, but if not, then definitely as a light chain deposition disease, I would have done exactly what Dr. Ghazi has done, is just to follow him up. And it seems, I mean, don't argue with success. Dr. Ghazi followed him up for 2 years now, and he's still under mission, which is good, I guess. Dr. Ghazi.
So I mean, transplant in amyloid has been a very debatable topic in the last, I would say, year or two. So with people achieving in-organ responses quite quickly, is a new role for transplant. And the ISA with the EHA consensus statements that came out last year, they have actually decided that anybody who achieves the CR at the end of induction, they shouldn't actually go for even a collection. They should actually continue to be monitored. At the time of relapse, you couldn't reinduce them and transplant them. So, and again, I think transplant was in a time when induction was not great. So, you really have to push that organ response, deeper. In our case, I mean, you achieve the CR. What else are you trying to do? This is a small clone. Yes, it's reaching the myeloma, cusp, but there's no organ damage. Like the full body MRI is negative. PET scan looks pristine. The calcium, kidney function, hemoglobin, everything looks normal. Like, I don't know what I was trying to treat if I wanted to transplant it.
I have my own comment about the numbers. I remember, I forgot who it was. I think it was Mikhail, what's his name? About the exact, like being like strict about the 10% cutoff.
Right.
I remember he said something about like if you have an 8%, where whatever renal manifestation of that. I mean, you don't need really to wait for that, like that cutoff. Having said that, you mentioned the transplant part. I mean, when you're talking about the case, and I was thinking, would I transplant this patient or not? I mean, it's not exactly amyloidosis, and the reality is we don't have enough data to support transplant or not. I guess in these cases. It's just extrapolating from the
But
I think
can you call this a renal disease with myeloma? This is not CAS nephropathy. This is.
It is not. It is not. It is not. Technically, it is not. I know.
Definitely.
I know. I would definitely consider it as an MGRS.
Right.
I think Dr. Ines is with us. I think we had a case couple of years back, or 3 years back, I think before I came back, I think where she had an MGRS and we transplanted the patient, and the patient continued to have a CR till now. I think for 5 years. I think no recurrence of the disease. So I mean, we had some success with transplant. I guess a case that I remember at least.
Right.
Actually, I had like 3 cases I can remember. This MGRS or light chain deposition disease, 2 cases end-stage renal disease. And at that time, only King Faisal was doing transplant, and I wanted to push the patient for transplant, but with renal impairment, they were not accepting. And more recently, I had another case. I even spoke to Shaji Kumar. He said it was LCDD again. He said, go for transplant. I think there is some variation in practice. Some people tend to be aggressive, and younger patients push for transplant. What do you think, Dr. Ghazi?
I mean, to be honest, I think the goal is to, if you think about the pathophysiology of the disease, there's a toxic clone that's actually damaging the kidney. So if you're able to eradicate that clone to the least amount of burden you can do, and the kidney function reversed and the kidney is back to normal, it's very difficult to justify the need for transplant at one point. I mean, I think this is on a case-by-case basis you have to decide, but we eradicated the clone with only daratumumab-based therapy. Kidney function is back to normal. This guy is still young. I thought, we'll just, stop therapy completely, continue to monitor him. If he relapses again, he will remain young, he will remain transplant, eligible. And I think he will, do, very phenomenally with the retreatment with daratumumab to achieve a response, and then I'll probably transplant him at that time. But you guys highlighted important points. I think one of them is you really think about the disease, pathophysiology on the not every ingredient damage is a myeloma-defining lesion. This guy certainly is not myeloma based on the pathophysiology of renal involvement, and the percentage of plasma cells. We have a pathologist here, and I hope some of them are actually listening here. Sometimes they torture you with the plasma cell percentage. So not too long ago, they wrote something in the. They said, this is a different case, but they said plasma cells are 8 to 12%. Like, really,
but Dr. Razi, for a fact, I mean, just for the sake of argument, I mean, the definition of multiple myeloma has evolved and changed from time to time. Previously, we used the definition where you need only to prove monoclonal plasma cells regardless of the percentage, and then you can diagnose multiple myeloma. I mean, the cutoff point of 10% is not really something that really defines and draws a definite line between MGUS, for example, or other diseases, but we know for a fact, like in amyloidosis, you may diagnose amyloidosis without finding a clone in the bone marrow, and the burden of the disease is quite high, especially if you have cardiac amyloidosis. And these patients also have a problem with tolerating treatment, as you know. I mean, it's not only the clone size, it's the damage that is seen behind that, whatever clone is there.
Right, and I think also we need to highlight the importance of a good renal pathologist. These entities are super difficult to diagnose. If this is a 60-year-old guy, you could have just said, well, this is an MGS, and if the pathologist did not give us a diagnosis, we'll just sit on this hematuria for forever. So renal pathologists are really paramount in diagnosing MGRS. And never give up. Honestly, we always argue, and I ended up, sending these cases to Sanjeev at Mayo Clinic. And in the last couple of years, they win, most of the cases. But last year, I won a case where they said FSGS, and it came back to be an AL amyloid. So these are really difficult cases, and you need really trained renal pathologists.
All right, thank you. Any other comments?
What would you consider doing now that the immune fixation is positive 2 years out? Would you just continue to?
Yeah, I mean, it's super tough. Honestly, I think I'll just continue to monitor the kidney function, and then if the kidney started to change, then I'll probably reinduce him again and take him to transplant. But I'll just sit down. I'll sit on this immunofixation. So his kidneys are normal. He's doing clinically well. Is there any justification to take him to retreatment now? Could this fade away with time? I think time will tell.
If and when you do actually decide to treat, would you go back to the RVCD?
It's been 2 years now. I think I'll probably do the same. So I'll probably do data VCD, and then if he doesn't respond, within a month or two, then I'll switch therapy. But if you recapture the response, then it's probably reasonable to just retreat with the same therapy and just debulk him with melphalan.
Yeah, very reasonable.
السلام عليكم دكتور غازي يعطيك العافية. الله يحييك. Regarding the second case, and as you mentioned, this is rare, and usually we treat them with radiotherapy, as you mentioned. I would like just to ask you, how would you follow up this patient? Because usually we look for either local recurrence or progression to myeloma. So in your case, what's your plan for follow-up and monitoring?
Yeah, so when those this is a secretory plasmacytoma, so the bone marrow is negative; it's not secreting, but the lesion itself is secreting an IgG kappa. So usually we follow these things, I would say monthly, and I will probably do a PET scan every maybe initially at 3 months, and then later on every 6 to 9 months, and then beyond this every year. But I think the PET scan is what diagnosed this initially, so we'll go back to whatever diagnosed this patient as a monitoring modality.
Thank you, Dr. Ghazi. It was very interesting. And thanks, Dr. Ayman. I just want to share one of our cases. So this patient was 65 and presented to the surgeon with interception. Post-surgery, the diagnosis came intestinal plasmacytoma, and it was a solitary lesion. First cytogenetic bone marrow were negative, and I don't have PET-CT at that time. That patient disappeared for almost 6 years, and then he presented with the pathological fracture of his knee, seen by orthopedic. It was a plasmacytoma, and then referred back to us. So, I mean, I don't know how would we define this patient? Someone who has plasmacytoma intestinal, went, no treatment, 6 years back, he came with pathological fracture. Currently it's on treatment. So he presented with 2 extramedullary disease and did not require any treatment for 6 years, which was interesting.
But when he came back with a pathological fracture, what happened to the original plasmacytoma where he had no treatment? The intestinal plasmacytoma, is it there or did it disappear? What happened?
No, it disappeared because I did for him, I don't have PET-CT, but we did for him CT with contrast, nothing really. And the rest of the myeloma workup came positive, bone marrow was positive. I treat him now. I'm not sure.
So he progressed into multiple myeloma, right?
Yeah. Yes. But initially it was plasmacytoma, and he disappeared, refused to receive anything. 6 years back, he presented with another extramedullary. For me, it's an interesting to stay 6 years with nothing. No treatment, no follow-up.
Yeah, I mean, these are indolent diseases, and the 6 years in my mind is too long, but it's an indolent process, and he declared himself to a myeloma. So unfortunately, if you have, I think if small lesion in the bowel was resected long time ago or irradiated, I think there's a good chance that he could have been cured.
Yeah, but he refused at that time the irradiated. He was a bit scared, and then again 6 years is a good time.
Yes, it is a good time actually. Yeah.
To stay with nothing.
If you allow me to try before you close, I want to highlight the.
Can I have a question?
Yes, go ahead.
I don't possibly know the answer. If these kind of
Yes.
What's that?
Yes, go ahead.
I mean, in cases of MGRS, that's let's say that do worse. I mean, I probably know. I mean, we kind of know the answer. But I mean, let's say you take them into a CR. I mean, at certain point, and they come back. I mean, would you consider kidney transplant in those patients at any point in time if they fail, or if their kidney fail at one point?
That's actually a super important question. If they are in hematological response, there's actually full consensus statement on this. People who get renal amyloidosis and they burn their kidneys, if you can take them to a complete hematological response, if they're in heme CR, it's probably justifiable to do a kidney transplant because their median PFS is more than 5 years, and what you need for a kidney biopsy survival is 5 years. So it's very reasonable to do that, but you have to have a CR.
Right.
In fact, I have a lifetime deposition disease patient with end-stage renal disease, and we transplanted him. He was like 3 years without any active disease, and he got
just proving the concept. Yes.
So Omar, just want to highlight that there's actually a blood publication this year that looked at teclistamab in first relapse in renal amyloid, and numbers are impressive. I think teclistamab is very powerful to eradicate those
دكتور غازي ما ادري هو
interest relapse. So maybe when my guy relapses, you don't have access to teclistamab. Who knows?
I'm pretty sure it's gonna come. It's gonna be on board in the next coming few years.
All right. Any further comments, or Dr. Ghazi, you wanted to say something before we close?
Thank you. Much appreciated.
Huh? Anything? No?
Thank you.
Dr. Ayman, if you allow me, just a quick
yes.
comment.
Yes.
Sorry, I joined late. Regarding the radiation dose, it's very important to discuss with the radiation oncologist. And in my experience, radiation dose 45 to 50 Ky is needed for the eradication of cerebral plasmacytoma. I wouldn't go below 45%.
Correct. I agree with you. I mean, because I mean, you have to make sure that the radiotherapist or the radiation oncologist understand that he's giving a curative dose of radiotherapy to this solitary plasmacytoma, because sometimes, I mean, when you tell them this is plasmacytoma and they think this is just part of myeloma, they may give just a palliative dose, 5 sessions or so, and then, I mean, patients progress with that. I totally agree with you, yes. Any further comments? If there are no further comments, thank you very much, Dr. Ghazi, for these 2 interesting cases. We had very nice discussion. This was really enlightening. And for the audience, thank you for watching. And this is, again, just to mention for those who have joined late, this is the first wave of a series to come that is going to be monthly under the umbrella of the Saudi Myeloma Working Group. And we're happy to have you there. You can send us your comments and suggestions to the group. And thank you for watching. Thank you for everybody. Thank you for the members of the group. And thank you for Jansen for supporting us and sponsoring this meeting tonight. Thank you very much and have a good night. Barat al-Nasr is soon starting. Thank you.
That's